Hi, everyone. I'm Brian Whaley, and for my final presentation, I'll be discussing an incentivized malaria prevention program in rural Benin. Benin is a small nation in sub-Saharan West Africa, where malaria is one of the largest public health issues. It's endemic and is the leading cause of mortality for children under 5 and morbidity in adults. According to the President's Malaria Initiative, it places an enormous strain on Benin's economic development, with an estimated 1/4 of a family's annual income spent on malaria prevention or treatment. Though there are proven methods that control mosquitoes, the vector for malaria, in indoor residual spraying or insecticide-treated nets. Those have been shown to reduce the number of cases in some of the most vulnerable subpopulations in the country. And given that malaria is endemic, Benin has a history of widespread bed net distributions, both on a local and a national scale. Benin is also the country where I served as a Peace Corps volunteer, and part of our rural community health framework was addressing malaria prevention methods. Though there is a gap in the use and ownership of ITNs, and in rural areas where they may be needed most, there is a consistent lack of follow-up. On the left, there is an image of nets being repurposed as garden fence in Uganda. On the right is an image of a bed net being used as a fishing net on Lake Victoria in Kenya. And these two images of bed net misuse are consistent with my experience in Benin, where I saw families repurposing nets for different uses around the house, rather than leaving them installed and used properly in disease prevention. According to the Rollback Malaria Partnership, ITN use consistently lags behind ITN ownership. And one of the goals of our study is to try and understand why that discrepancy exists between ITN use, maintenance, and ownership, the attitudes and perceptions, and maybe the motivators that go into non-use. An overarching goal of our study is to, of course, reduce the incidence of malaria in Benin's children under 5 subpopulation, and reinforce rural networks of community health workers who play a vital role in disease prevention and improving access to care for people who live in rural areas. Our more focalized research questions ask about the incentivized nature of ITNs. If the use of ITNs were to be incentivized, does that actively encourage their proper use and maintenance? And does that in turn reduce the local incidence of malaria among children under 5? The backdrop for our study will be the Atakora department in northwest Benin, comprised of 9 communes in total. Our study will be a clustered randomized control trial that will take 8 villages from 4 of these communes for a grand total of 16 control villages and 16 intervention villages, chosen randomly, and they'll be matched by eligibility criteria, such as population demographics, climate, which plays a large role in the reproduction of mosquitoes, the vector for malaria, and their proximity to healthcare and existence of community health worker networks. The study will be conducted over 2 years, not only to establish temporality, but to capture the sometimes up and down rates of malaria during both the rainy and dry seasons. Mosquitoes really like water, but in order to achieve a bigger picture, we want to capture both of those seasons. Now, a randomization of the communes and villages will ensure blinding and also prevent contamination between the control and intervention villages. The intervention in our study will be an incentivized use of the ITNs with healthcare vouchers redeemable for malaria prevention and treatment services, and biweekly community health worker follow-ups, which as part of the intervention will be instructional and corrective. The control group will still receive the follow-ups, but they will be purely observational in nature. Our target population in the study will be family units with children under 5 in the household. We're aiming for 30 households per village, but maximal coverage would be ideal. And we'll use the Ministry of Statistics population census to identify and enroll these households. In terms of our BedNet distributions for the control and intervention villages, we'll use President's Malaria Initiative and Ministry of Health data, looking at past distributions. We'll also partner with community health workers and the local health centers to help put together a distribution, though no distribution can be successful without the support from local community leaders. And in this image here is the local distribution in Nata, the region where I served as a Peace Corps volunteer. The man in the red clothes there is my counterpart, MPO, a community health worker who is working hard to allocate those bed nets for families. Now, part of the study is building capacity of regional community health worker networks. And part of the study will be conducting follow-ups and household questionnaires. And part of the recruitment on that end will be finding community health workers who can assist in the training of others throughout the study. Other inputs that will be going into our study are the funding and resources for the health center vouchers and the ITNs themselves, the infrastructure and technical training, and the engagement in the community. That will play a huge part in the success of this study, as well as the community health workers and health center personnel themselves. Some of the activities we will be conducting, of course, the ITN distribution at the beginning of the study and the voucher distribution to those enrolled households in the intervention villages. We'll also be conducting workshops and meetings over the course of the study to make sure that biweekly follow-ups are being conducted and that the community partners are being engaged and mobilized throughout the study. This will give us the number of total nets distributed to families throughout the study, the number of health center vouchers, that were redeemed by enrolled families, the number of follow-ups conducted by the community health workers, and the differences in the pre and post-test scores. And this will give us the percent of households that are correctly using their bed nets. And the number of health center visits due to malaria will hopefully be reduced and lead to educated and healthy families in our communities. The data collection for our study will use 2 modes. An in-person mode will be comprised of pre and post tests that cover disease prevention as well as hygiene and nutrition, and a malaria indicator survey household questionnaire, which will be conducted bi-weekly with our enrolled families by the community health workers. That will ask about household demographics, the attitudes towards ITN ownership and use, and any changes in the health status of the children. Our secondary modes, of course, will be looking at the distribution records to get the total number of nets distributed, as well as the municipality health records post-study to get the total number of vouchers redeemed, the services provided, and the number of malaria cases diagnosed in our enrolled children. This is an example of the malaria indicator survey household questionnaire. As you can see, it addresses the number of ITNs that are in the house, if they're being used properly, Are they regularly checked, maintained? And there's a space there to list any symptoms of anybody in the household that may be suffering from malaria. Though there are several limitations and threats to internal validity that I would like to address as part of our study, a clustered randomized control trial is somewhat atypical in a community health setting. One could argue that the lack of control of outside factors and the lack of clinical setting can make these results somewhat not practical or inapplicable to the real world, though I think a strength that makes our study more applicable is the fact that it's being conducted in real time in the real world. There are historical and current malaria interventions besides our study that are ongoing in sub-Saharan Africa, and that could confound the results of our study and possibly skew them, with many villages in Benin having been subject to previous malaria studies. That also leads to the threat to internal validity of testing, where the pre and post tests and household questionnaires could alter the behavior of control villages without intending to. Of course, there's ethical concerns when dealing with such a serious disease as malaria. And to address this, we'll be taking usual care of our active control group by not withholding bed nets. The control group will receive bed nets, and at the end of the study, they'll receive the phased implementation of the community health worker follow-ups that the intervention villages received over the course of the 2 years. Though a large threat to internal validity is selection bias on behalf of the relationships that community health workers have with families and different households, as well as the role that local politics can play in the allocation of resources. This can be countered by strict randomization in the communes and villages, and the conducting of universal training on how these community health workers should be conducting these follow-ups and questionnaires. Our study will hope to address the issues of access to care in rural areas and a lack of follow-up on behalf of community health workers post-ITN distribution, and in the overall context of malaria prevention for children under 5 in Benin. We hope to understand the different perceptions that go into ITN ownership and continued use, and the factors that contribute to a decision to not use a bed net and maybe use it for a garden fence or a fishing net instead. Also hope to understand more the role of community health workers in rural health and improving access to care, access to knowledge, and access to disease prevention methods. In the future, this study can address vector control research in sub-Saharan Africa and help to bolster the distribution database of ITNs, and also provide evidence for successfully conducted community-based RCT. As stated in the 2006 paper by Rosen, several studies have been conducted in a community setting, in real time, in the real world, that have applicable results. And it will also add to the training and capacity building of rural health systems in sub-Saharan Africa, which are probably the greatest contributors to disease prevention and behavior change in rural areas. Thank you so much. I look forward to answering your questions and hope y'all have a great rest of your day. Thank you so much.